Next, we will hear from Dr. Jessica Cohen, the Bruce A. Beal, Robert L. Beal, and Alexander S. Beal Associate Professor of Global Health at Harvard T.H. Chan School of Public Health and co-director of Harvard's Lead Fellowship for Women Global Health Leaders. She is a health economist well known for her research on maternal and child health policies and programs in the United States and East Africa. Under a recent NIHCM grant, Dr. Cohen and colleagues published new research on the impact of Medicaid reimbursement on immediate postpartum LARC use. We are so grateful she's with us today to share her perspective and research. Dr. Cohen?
Great, thank you so much for inviting me. I'm very glad to be here with this esteemed panel. I'd just like to mention my co-authors on this research, Maria Steenland at Brown University, Raj Vatsa, who is a MD PhD student at Harvard with me, Lydia Pace, who's at Brigham and Women's Hospital and Harvard Medical School, and Anna Seneko, who's also at the Harvard Chan School of Public Health. And thanks to NIHCM for funding and to NICHD and the Harvard Chan School. So let's get started. Could you turn the slide, please? Thank you. So there's still a very high rate of unintended pregnancy in the US. Although the data is a little out of date, something like 45% of pregnancies were unwanted or were wanted at a different time in the US. And these rates are highest among adolescents, racial ethnic minorities, and lower income populations. And unintended pregnancies, has already been mentioned, are associated with adverse maternal and newborn health outcomes, for example, preterm birth, and also with lower educational attainment and earnings. Next slide, please. Thank you. So the great majority of postpartum pregnancies are unintended. Fully 80% of pregnancies that happen within 6 months of a prior pregnancy were unintended. And even if you go up to 6 months to 11 months after a prior pregnancy, 70% of those pregnancies are unintended. Next slide, please. Thank you. So these short interval pregnancies, pregnancies that happen within a short interval of the prior one, are also associated with a range of adverse maternal and newborn outcomes. So the American College of Obstetrics and Gynecology guidelines recommend avoiding interpregnancy intervals that are shorter than 6 months. And the World Health Organization actually recommends interpregnancy intervals of 2 years or more. So ensuring that postpartum people have access to freely choose among the full range of contraceptive methods is really key to preventing these unintended short interval pregnancies that occur throughout the postpartum year. Next slide, please. The problem is that in the US, as in many other places, postpartum people face what we refer to as postpartum cliffs. In other words, they have quite a lot of health system scaffolding to ensure their access to healthcare during pregnancy and delivery, but that support falls off abruptly in the postpartum period. Next slide, please. So in particular, birthing people have a strong connection to the healthcare provider and system that develops during pregnancy and delivery, but this often fades or even plummets postpartum. And so many people within the United States receive no postpartum visit at all, and even those that do often don't get comprehensive postpartum care or appropriate transitions to primary care and contraception. So contraceptive options that are available during the delivery admission, that is immediate postpartum contraception, can really offer a tremendous opportunity for unintended pregnancy prevention for people who may lose access to affordable or high quality care in the postpartum period. Next slide, please. Until about 10 years ago, the only options for immediate postpartum contraception were tubal ligation, progestin-only pills, or injectables. So these are either permanent methods or short-acting methods only. But IUDs and implants, or long-acting reversible contraception, often referred to as LARCs, which are the most effective forms of reversible contraception, were not really widely available. Next slide, please. So until about 10 years ago, immediate postpartum LARCs weren't offered. And why was that? Well, the device, the IUD or implant, and the procedure, the insertion, are costly. but these would only be covered as part of the global fee for labor and delivery or childbirth. In other words, if healthcare providers decided to offer immediate postpartum LARC to delivery patients, they would be doing that on their own dime. Their payment reimbursement rate wouldn't go up. And so momentum grew from clinicians and policy experts, women's health advocates, and researchers to unbundle the reimbursement for immediate postpartum LARC from this global payment. In other words, separately reimburse for the insertion or the device. Next slide, please. So South Carolina Medicaid was the first state to adopt this policy of unbundling the immediate postpartum LARC from the global delivery payment. But the majority of states have adopted this unbundling of state Medicaid programs have adopted this in some form since then. Next slide, please. And so my research, along with this research group, started with a focus on South Carolina, since that was the first state to implement this policy and have the most data on these folks. So in this paper, what did we do? We looked at the impact of the Medicaid payment for immediate postpartum LARCs on LARC use in South Carolina. So what these graphs are showing, so this data was linked hospital discharge data with birth certificate data from all of the Medicaid births in South Carolina. And this was an interrupted time series analysis looking at the impact of the introduction of this policy on trends in immediate postpartum LARC use. So what you're looking at here is time on the horizontal axis, and the horizontal line is the introduction of the Medicaid policy, and each dot here is a month. So this is showing you the fraction of deliveries paid for by Medicaid in South Carolina in which an immediate postpartum LARC was placed. And what you can see is that after the introduction of the policy, the trend in IPP LARC placement goes up dramatically. On the left is adults, that's people 20 years and older, and on the right was adolescents. The increase by the end of this study period, 2018, was a 5 percentage point increase in immediate postpartum LARC placements and an 8.3 percentage point increase for adolescents. Next slide, please. So then in further analysis, we looked at the impact of this on 5 other early adopting states. So those were Georgia, Iowa, Maryland, New York, and Rhode Island, which implemented the policy in 2014 or 2015. And for this, we used state inpatient database, the state inpatient database provided by HCUP, linked to American Hospital Association surveys and other data sets. And again, we used an interrupted time series to look at, did the trend in immediate postpartum LARC placement change after the introduction of the policy? So again, the way to look at these is the dashed line is the introduction of the policy. The blue line shows you that in most states, other than Iowa and Maryland, the trend in immediate postpartum LARC placement was pretty flat prior to the introduction of the policy and then increased quite a bit. You can see there's quite a lot of heterogeneity across states, so that the biggest effects were in New York, Georgia, and Rhode Island, smaller effects in Iowa and Maryland. Next slide, please. So what we found across the board, both in our earlier work in South Carolina and then this later work in the other states, was that adoption of this, the offer of this method was not adopted evenly across facilities at all. So the offer of immediate postpartum LARC, even after the introduction of this Medicaid policy, was really only offered in a handful of health facilities. So on the graph on the left, what you can see is that across Georgia, Iowa, Maryland, New York, and Rhode Island, even after the introduction of the Medicaid payment, 73% of facilities were not inserting immediate postpartum LARCs in any deliveries, and then another 17% were doing it in only, less than 1% of deliveries. So really, the sort of 1% to 20% of deliveries getting the immediate postpartum LARC was only happening in 10% of facilities. The graph on the right basically shows the same thing in South Carolina. Next slide, please. We also looked at characteristics of facilities that adopt immediate postpartum LARC. What we found was that the handful of facilities that were offering them were overwhelmingly likely to be urban, non-Catholic, high-level teaching hospitals. Next slide, please. Another thing that we found that was quite interesting is that the introduction of the Medicaid reimbursement for immediate postpartum LARCs spilled over a bit into commercially paid births. So if you look at the graph, for example, on the bottom left in New York, these are the fraction of deliveries, commercially paid births in which an immediate postpartum LARC was placed. You can see that after the policy, there's an increase for commercially paid births in some of these states as well, in New York, Rhode Island, and a bit in Georgia. Next slide, please. So again, since we've had longer to look at South Carolina, it was the first one, we've dug in a little bit deeper into the impact of this policy change. So one of the first things that we saw that I think was really interesting was that along with the big increase in immediate postpartum LARC use in South Carolina was a sizable decline in tubal ligation for adult women. In other words, we seem to observe a sort of switching from permanent sterilization toward LARC. On the other hand, for adolescents, birthing people under 20, we did not see that switch, not surprisingly, since many of them are not getting tubal ligation, but actually saw an overall increase in the use of effective contraception for adolescents. Next slide, please. We also, in South Carolina, looked at the impact of the policy on short interval births, which I mentioned before are often unintended and which are associated with adverse maternal and newborn outcomes. We didn't see an overall change in the likelihood of short interval births, but we did see a significant decrease in short interval births among adolescents in South Carolina, and also a significant increase in birth spacing for adult non-Hispanic Black adults. Next slide, please. So this is just showing you the interrupted time series results for short interval births for adolescents. It's a pretty sizable, you saw that there was a big increase in immediate postpartum LARC use for adolescents. This seems to have translated into a reduction in short interval births of 5.3 percentage points. Next slide, please. We also in South Carolina see evidence that the Medicaid payment for immediate postpartum LARCs led to reductions in preterm and low birth weight births. Next slide, please. So the effects were somewhat modest, but we did see a significant reduction following the introduction of this policy in rates of preterm birth, low birth weight births, and in particular the moderate preterm births, and not the very preterm or very low birth weight. Next slide, please. So just in sum, the state Medicaid policies to unbundle immediate postpartum LARC reimbursement from the global fee have increased use of this method across a range of states, although the effects vary. The adoption, however, of the offer of immediate postpartum LARC across facilities is very uneven, with only a handful of facilities offering it, meaning that access to this method is definitely not uniform for birthing people. There is some evidence of declines in short interval births and adverse birth outcomes, although not across the board and for all groups. And this is something we continue to look at in our research group. The policy, of course, of reimbursing for immediate postpartum LARC is meant to increase patient choice, right? To increase the options that are available to postpartum people. But evidence is needed about whether patients are receiving patient-centered, complete, and unbiased counseling regarding immediate postpartum LARC to ensure that the policy is actually increasing choice. And finally, I think we need more information on the modifiable factors that are influencing adoption of immediate postpartum LARC at facilities in order to ensure that this method is more widely available to patients. Next slide, please. So just would like to thank you very much and welcome your feedback and suggestions. And again, thank my collaborators and Nikum for the intro, for the invitation to speak today. Thank you.
Great. Thank you so much, Dr. Cohen, for sharing your research and giving us a foundational understanding of the role that Medicaid reimbursement can play in contraceptive access and use.